I'm Dr. Jim Amos, and I'm a staff psychiatrist at University Hospital in Iowa City, Iowa. And this is yet again another dirty dozen, this time on common problems in consultation psychiatry. And I commonly encounter several problems that I've shortened to a list of about a dozen or less to talk about in this slide set. This presentation is probably best viewed on my blog site, The Practical Psychosomaticists, which you can access at thepracticalpsychosomaticists.com. And the short list, as far as I'm concerned, and of course opinions will differ about this, is triage, delirium, suicide and violence risk assessment, legal issues, depression assessment, personality disorder, education, alcohol withdrawal management, decisional capacity assessment, and other important issues that I commonly encounter. So I'll follow along with the slides here. And of course the first issue is triage, which is how do you get the patient, or how do you decide how to get the patient from one area of the hospital, usually the med-surg unit, to inpatient psychiatry. Now this will necessarily be a quick overview. There's really no time to do comprehensive presentations on each one of these issues. This is meant to be a broad overlook, mainly for first and second year residents in psychiatry training. Triage is commonly encountered after patients attempt suicide or otherwise need to be evaluated on med-surg units before transfer to inpatient psychiatry. Often when the patient can't be transferred to psychiatry immediately, we try to help inpatient medical teams decide when a sitter is needed for the patient's safety. Another question to consider is whether psychiatric hospitalization is always necessary. It's a good idea to think beyond triage, such as what are the available outpatient mental health resources after discharge, and are family and other social connections intact so that the patient can feel safe and cared for when outside of the hospital. Delirium is the second item, and it's a common problem in the hospital, about 20% in the general hospital and about 80% in ICUs and palliative care units. It's a medical emergency, and that's what I usually advise trainees to think about first. Emphasize a diligent and urgent search for medical or medication causes of delirium. Check for medical contraindications to using antipsychotics to control dangerous agitation, such as prolonged cardiac conduction, which can militate against using antipsychotics, especially injectable formulations. Remember the scope of practice of psychiatrists. Educate families, the medical team, and remember that collaboration is the key to preventing delirium. Now, on most of these slides I'll have links to presentations, usually dirty dozens, but not always, on other presentations that I've made about specific issues like this on my blog site. Suicide risk assessment. Often patients after suicide attempts, especially by overdose on medications, are groggy, and they're also obtunded, some of them, in the intensive care unit environment. It's really important to obtain collateral history from family, friends, and outside healthcare givers in order to round out the picture of what exactly happened so that you can provide the safest care possible. You can always ask about suicide ideation. Assess protective factors as well as risk factors. Avoid so-called no-suicide contracts. They don't protect patients from suicide, and they don't protect doctors from lawsuits. Consider working on a safety plan together, both as an assessment tool and as a resource for patients after their discharge from the hospital. Psychiatric hospitalization is the default safety plan. Violence assessment is very difficult, and given all the legal ramifications, there's really no way that I can give you a full accounting of what the psychiatrist should and even can do in situations like this. It's uppermost nowadays in light of highly publicized mass shootings. But it's important to remember that only about 4 to 5% of violent crimes are committed by those with mental illness. Those with mental illness are more likely to be victims of violence, and it's important to remember that. One important risk factor for violence is a previous history of violent behavior. As a practical issue, it's really prudent to wait until intoxicated patients who are threatening violence are no longer intoxicated and then return when they're in the hospital to interview them again about homicidal statements. Sometimes these patients will not remember making them. Legal issues, far too broad an issue to treat in such a short presentation. And probably the best advice I can give is to observe state mental health and substance abuse commitment laws in your own state and in your own jurisdiction. Follow your state statutes and hospital policies. Consult with your organization's attorneys. Weigh carefully the risks of involuntary hospitalization to the therapeutic alliance against the risks to the safety of the patient and others. It's typically tough to find a balance. As a general rule, in most jurisdictions, one cannot commit a patient to involuntary medical treatment, although in many jurisdictions it's possible to involuntarily hospitalize and treat somebody for psychiatric diagnoses. Depression assessment, a very important issue. It's possible to underdiagnose depression in the general hospital, and it's possible to overdiagnose it as well. Hypoactive delirium can resemble depression, and the two are often confused. No pun intended. Demoralization, grief, and adjustment disorders can mimic depression. Applying a major depressive episode label can be hurtful in some cases. Personality disorder education, and I labeled the issue this way because very often it's really unrealistic and impractical to expect psychiatrists to change in trained, chronic, maladaptive interpersonal styles in the short space of a medical hospitalization. Sustained maladaptive coping styles can sometimes interfere with medical and surgical treatment. These enduring, difficult interpersonal patterns typically cannot be changed to healthier ones during a brief hospitalization, as I already indicated. Sometimes it's best to advocate for a more tolerant approach to some behaviors. Picking your battles is another term for that, and allowing for empowering a patient to make choices regarding some items of care. And that can be prudent in helping people feel like they're more in control of a situation in which they don't feel like they have very much control. Alcohol withdrawal management, another large issue. Always try to find out when the patient's last drink was. More than occasionally, fixed dose benzodiazepine taper protocols can lead to over-administration of sedating medication, leading to intoxication, delirium. Use symptom-triggered withdrawal protocols whenever it's possible. The possible exception might be in critical care units where patients are intubated and unable to participate meaningfully in assessments using symptom-triggered withdrawal assessment tools. Avoid using beverage alcohol and prefer benzodiazepines. Those are the treatment of choice in managing alcohol withdrawal. Decisional capacity assessments. Many doctors believe that they cannot conduct decisional capacity assessments themselves, but in most cases it's possible for them to do so. Psychiatric consultants are better at assisting their colleagues in medicine and surgery by assessing whether or not a psychiatric condition is substantially influencing medical decision making. And that's an important role. It's good to remember that in most cases, psychiatrists are really not in the best position to actually conduct the risk-benefit portion of a decisional capacity assessment, especially in the cases of surgical treatments, because of scope of practice issues. Ideally, whenever possible, psychiatrists and their colleagues in medicine and surgery should try to conduct this assessment together with the patient. A lot of times, decisional capacity assessments turn out to be communication problems rather than decisional capacity assessment problems per se. Other important issues are sort of a mixed bag, but they're very important reasons why psychiatric consultants get called. Where psychiatrists are involved in transplant candidate assessments, psychiatrists are better collaborators than gatekeepers. Try to remember that. Emphasize more what it would take to improve the candidate's ability to be successful after a transplant rather than trying to be a gatekeeper. Medication issues are broad, and it's well to remember that some medications, such as serotonergic antidepressants, such as Prozac and Paxil, some of the older members are worse like those than other SSRIs, they can cause QTc interval prolongation and raise the risk for potentially deadly ventricular arrhythmias. They can also cause problems like low sodium, and antipsychotics can also cause cardiac conduction prolongation. Serotonergic drugs can potentially interact with other medications such as antibiotics. Linezolid is an antibiotic that has a monoamine oxidase inhibitor structure, and that can interact potentially with SSRI antidepressants. Deliberate foreign body ingestion can be a common problem in many hospitals, not just big academic medical centers. Usually it's safer to adopt a protocol where the medical emergency is treated first before calling the psychiatric consultant. Somatoform disorders, malingering, and factitious behaviors. The patient with a somatoform disorder often has other general medical conditions that ride along with the tendency to have medically unexplained physical symptoms. They have the right to both medical and psychiatric care. Malingering is an accusation, not a psychiatric diagnosis, but it can often be the focus of psychiatric consultation. Factitious disorder is a condition marked by a motivation to lie to doctors and other healthcare professionals in order to get medical and psychiatric treatments. Usually the motivation is assumed to be to assume the role of patient, because that's the way they can get emotional needs and the need for care met. However, it's very difficult to impossible for a psychiatrist or any other doctor to ascertain what the internal motivation of the patient is. The real challenge is to attain a working therapeutic alliance and avoiding evaluations and treatment which could put patients who have medically unexplained physical symptoms at risk for harm from medical treatment. Catatonia is another one of those rare conditions that psychiatric consultants are often called about, and it can be a complication of a medical disorder or a psychiatric disorder. And the quickest way to induce the mute immobile form of catatonia to resolve is to apply the intravenous lorazepam challenge test. It doesn't always work, but often it does, and it can look like a miracle, so it's worth considering that in cases of catatonia in the general hospital. Well, that's a quick overview of those common problems that are seen by psychiatric consultants, at least this one, in the general hospital. And I hope you find it helpful. There are links to more details about all of these problems on my blog site, and you can find them in other useful websites as well. Thanks very much for listening, and I welcome your comments.